Hey all, welcome to ShareTrack. This is Raj here. Friends, I have a treat for you. Your favorite Jeff Galvin from Addimmune and American Gene Technologies was here today to talk with me about Addimmune, about AGT 103-T, and all the wonderful things that they are doing out there at Addimmune. So I hope you enjoy this video. The rest of the video is the interview. Let's get started. Hi, Jeff. Welcome to ShareTrack. Our viewers have been asking about when you join us. So I'm really glad that you are able to give us some time and join us today. Welcome.
Oh, pleasure to be here. Thanks, Raj.
Yeah, I would go right into the questions, Jeff. I know that you're a busy man and you have limited time. So my first question for you is that since the launch of Addimmune, how has your role changed? I mean, there must be a difference between just running American Gene Technologies and now running AGT along with Addimmune. So what's your typical working day looking like? Has it changed?
Yeah, it's changed a lot, but I think that it's changed in a very important way that's more scalable. So one of the things that's happening now that we've made this decision to move forward with Addimmune into the public market is that we've hired top-notch people with deep experience in every area. And so my job is more about delegation now than it was, doing everything. There was a time, you got to remember, where the only thing we had in the company was R&D and me. So I did everything. It was a big relief to me when we started getting some finance people in, because at least I didn't have to keep the books and file the taxes and, do all that stuff. But now we're way past that. I've got a robust marketing department. We hired a VP of marketing with a tremendous amount of experience. His name's Grant Smith. We hired an experienced public company CFO, Nick Tressler. I don't know, I assume I had my chief of staff the last time I talked to you, but Karen McCord. So that takes some burden off of me. We just found out yesterday that we're very likely to have found our person to join as our general counsel.
Wow.
Which will, take some of the burden of me talking with the attorneys, or trying to talk to the attorneys through other people that are qualified, but not as qualified as actual general counsel.
Right.
So that's the big difference. And this is very important to the future of Addimmune as well. We're like roughly a 50-person company right now, but as we hit additional milestones on the Addimmune side, I expect the company to grow substantially.
Right.
So, we can't allow the CEO's office to become the narrow part of the pipe.
Yes.
Right. And I think that everything that we're doing right now is clearly in preparation for that, and it is changing my life in that way. But I think it's a good thing. As for running both companies, I won't be doing that. So as we come to the split, I'm going to focus entirely on Addimmune. My job is going to be to make sure that Addimmune is successful.
Right.
And we have a whole dedicated staff that's going with this, the spin out of the non-HIV assets that will then be renamed American Gene Technologies, because that's a appropriate name for that company, the platform, and
right.
And also this variety of projects across immuno-oncology and monogenic disease and autoimmune diseases, things like that. So that's going to get spun out. We're going to name actually a CEO of that company. We don't know who that is yet, but I'll be on the board of directors. I'm still a big shareholder over there.
Right.
But I won't be operationally involved in it anymore. It's going to take my full attention to, push forward as quickly as possible on trying to get to a functional cure for HIV, and also to deal with being a public company and make sure that, we're a good entity within the public realm that, can keep the flywheel going with, funding and accomplishment and milestones.
This is amazing, because I think most of the viewers of our channel will be really happy to know that they still have your undivided attention focused purely on AGT 103-T within Addimmune. So that's a very positive development, I guess, for all of the people who are looking for a functional cure. My other question for you, Jeff, is that in our channel, I see a lot of people pinning their hopes on AGT 103-T. Everyone is asking, when is it coming? And it's going to be a functional cure. Explain the functional cure. I have told them so many times the same thing again and again, but they want to hear it again. So that's the kind of enthusiasm. And I think that you also feel this sentiment wherever you go. So how does it impact you knowing that people have such lofty expectations? And of course, we are in research and anything can happen.
Yeah. Okay. So there's a lot of different elements of that. Yes, I get it all the time. It's in all of my social media feeds. It's in my email even. There's a tremendous amount of hope, or even in some cases, I would say desperation, that people really want to move from living with HIV to not thinking about HIV anymore. And that's what a functional cure would, I believe, bring, is that, this is our intent, is to try to get to that point where we can do a one and done therapy on people and they don't have to think about HIV ever again, because functional cure means they aren't contagious, they can't get AIDS, and then the other Benny is that they can't get HIV back. It's really out of their life forever.
Yes.
And they can do that without additional medication. So they're the same as everybody else on earth. And I think that's what they want. And I completely understand it. And I get a clear sense of how important this is to people that are living with HIV. It also seems to be very, very important to people that know folks that are living with HIV, or that have a background where they remember the AIDS epidemic and they may have lost friends, family, even lovers in that. And they are also passionate. If you look at the number of people in the United States that feel like this is a high priority, I think that you could estimate there's about 20 million people overall. That's a lot. Think about that. That's, it's not quite 10% of the population, but that's big. So, this is one of the things I glean from my interaction with people living with HIV, and some of the inbound messaging I get, and a lot of the reading that I do online and things like that. But pressure, right? Well, nobody's putting more pressure on me than me. Okay, nobody has more lofty hopes and aspirations for this project than I do. It's not because I have HIV, no, but this is my baby, right? Yes. This is my baby, and this is my dream of doing something that would be, that would relieve suffering amongst, my fellow humankind. This was the reason I came out of retirement, is because I saw that gene and cell therapy had potential to lift up huge populations of patients. And I consider myself lucky that things worked out so well in HIV that we have been able to progress this into the clinic and start getting data that gives us additional confidence that this is possible, that we're on track. And, like you said, you don't know what will happen in the future. Yeah. And I can't tell you exactly how long it will take to, prove this out fully. Yeah. And to commercialize it, and then to start distributing it around the world, because there'll be other challenges of, how do we get it to, secondary markets that, that need a lower cost solution. Well, we're thinking about all those things today, right? So you can tell everybody that's watching this everywhere around the world, you're truly in our hearts. Everybody at the company feels that same way. And I understand and hear everybody, to varying degrees. People have learned to just, accommodate HIV in their life if they're living with it. Because if you look at like the HIV Cure Chronicles, you see all these really accomplished people there who have figured out how to put HIV in perspective, go on with their lives, and have great lives. And they look at HIV in a different way, as just, whatever, like any burden in life, right? Right. Everybody has challenges in life. HIV is a huge one. So I don't mean to estimate the impact of that, and also the shock value of finding out that you went from, never thinking about HIV to having it in your body. I think there's a shock factor there that is just really tough to get over.
Yeah.
So, we're thinking about all of them. We're thinking about, how do we get it to India? How do we get it to Africa? We're developing additional technologies that we can add into this to increase the probability that we can get to functional cure. So we
Right.
have 3 other projects on the bench. I can't talk about them because they're all,
Okay.
subject to patenting still. But these are all things that we think could increase the potency of this. And, if we can't get all the way there with AGT 103, okay, we got 104, 105, 106. And the cool thing about 104, 105, 106 is that they work on top of 103. So they
Right.
would increase the potency. It's other angles on controlling the viremia.
Right.
And so we may get all the way there with 103. Well, then those projects are still important. Why? That if we make a higher potency drug, we can produce it more cheaply. And
Yes.
that's the second mission, right? Is to then take advantage of the technology curve in gene and cell therapy, which hasn't really existed in biotech and pharma in the past, but it's always existed in everything I've done, right? Computers,
Right.
software, internet, IT, robotics, everything, AI just gets better and better and better and
Yes.
cheaper and cheaper and cheaper. And, if people who never would have dreamed of having a computer in 1980, now have a computer in their pocket, which is more powerful than the most powerful mainframe of that time,
Yeah.
right? Think about that. Okay, that's what technology does.
Absolutely.
So I have a 100% confidence that we will be able to, or that gene and cell therapy will one day deliver cost-effective solutions to a tremendous range of problems globally in every market. Okay, it'll get down to the most underserved nations in the world eventually. Okay,
Right.
so everybody's going to have faith and patience in that. But I also, think that we have, I'm cautiously optimistic that HIV will be one of those things where we'll sort of cross that line, fairly soon. And by fairly soon, I mean over the next few years, maybe we should get
2027-ish. Yeah.
yeah, we should get enough data that we know where we stand, right?
Right.
We'll sort of have that yes no answer.
Yeah.
And something good could happen that could move that up, and there could be some delay that moves that off. But I think it's very exciting that we're seeing that the stage of our company and the momentum of this project is gleaning attention in institutional investment circles.
Oh, that's interesting.
And that's very important.
Yeah.
When Wall Street recognizes, this could be a moneymaker too,
Yeah.
it's certainly less theoretical, than it once was,
Yes.
right? Now they're thinking, okay, it's a risk, but the path certainly looks like it's on the upslope.
Right.
And if, there's this light at the end of the tunnel that has huge value, and it seems to be getting closer and closer.
Yeah.
Okay. At least they're validating, my hopes and dreams and everybody out there's hopes and dreams who would like to see a solution to HIV. So, everything's, I think, there's a lot of indications that, it's reasonable to have some hope.
Yeah.
And also, I understand, how much people want this. Yeah.
Jeff, are you still, like last time we met, you were thinking that 2027 might be the approximate ballpark when a functional cure might arrive. Have you changed your mind on that, or you're still thinking the same ballpark?
Yeah, so as a CEO, I do kind of a if everything goes right scenario,
Yeah.
right? So, we do know that the raise is going well for this crossover round,
Yeah.
which is funding the next clinical trial,
Yes.
which it's reasonable to believe, based on everything I've seen, that we will be bringing in our first patients around the middle of 2024.
Okay.
Which means we'll be getting some safety data out of the study by the end of 2024, and that we'll have some preliminary readout in the middle of 2025. And the reason for doing this study is to get efficacy data that will power a what we hope will be a pivotal study.
Right.
Okay, so all right, so if everything goes right in 2025, we're starting to see some really good data. We might be by the end of 2025 talking to the FDA about redefining endpoints, right, for a pivotal study. So, again, everything goes right. And then the FDA still has to agree, right? But yes, that could put us, kind of 2026 could be that we start that pivotal study, and we'll be getting data out of it in 2027. And there are some populations within the community that's living with HIV where there's a particularly acute need, because there are some people that don't even respond to ART properly, and so they have a really hard time getting the right ART to control their virus. And so, there's, again, if everything goes according to plan, you could see that maybe the FDA around 2027 would be ready to give some sort of limited license so that we could start serving populations that can't live without this. Right. If the need is acute enough, the FDA does a, sort of a cost benefit analysis. Exactly. Right. A risk benefits analysis. Yeah. And, so 2027, if everything goes right, that would be realistic.
That sounds good, Jeff. The other thing I wanted to check with you was, can you tell our viewers what exactly happens with Addimmune, when and how they can get shares of Addimmune? This is especially for the investor groups that see our videos.
Okay, so if they are what are called accredited investors, and I think, foreign wealthy people are also able to do this, just go to our website, go to the investor section, find, our IR person, our head of business development, Barry Wells, and just contact him, because accredited investors are allowed to buy private companies. Okay. We're a private company and there is no public market for the stock. So it is a risk profile where the SEC has very strict rules about who's allowed to invest, because you have to have the not just the wherewithal, but you have to have the savvy to know what you're getting into. Okay. So if you there may be a billionaire out there listening to this who's like, I like this project, right? Okay, call us up. Right. That's obvious. Those people are obviously qualified. A lot of, you don't have to be a billionaire, but there's a lot of wealthy people. If we're successful in listing in the public market, then you can buy this anywhere you buy any stock. You can buy some IBM, and at the same time, you can get a few shares of our company as well. And we'd love that. It's a, when people buy shares in our company, and this has been true looking back as well, they generally do it for multiple reasons. I think that, in the early days, especially, people bought into the company because they thought this was an important mission.
Yes.
Right. And, they probably had some expectation that they wouldn't lose their money, but, that wasn't the main reason that they were getting in. And, it shifted, now that we're going to Wall Street. Well, people on Wall Street don't evaluate this as, what's the value to the public. It is, can this be a business, a sustainable business that creates economic value that can be capitalized on Wall Street and returns to investors? That's the other end of the spectrum.
Yes.
But, there is really a mix in there. Like, even those folks who only buy it because they think, oh, I'm going to make money on this, they don't realize it, but they're supporting the HIV, the development of an HIV functional cure. Our mission is supported by every share of stock that people buy, even if that's a trade between two people on the outside after we go public. It's still supportive of the company, because it's creating volume, attention. If the demand is high, if there's a lot of people that want to support this even in a small way, that is one way that they can do it, is, take a position. And that creates demand for the stock. And, that's something that has a ripple effect through, that eventually has some impact on our ability to keep pursuing this mission. I'm not suggesting that people buy the stock. This isn't a solicitation. I'm just trying to, as elliptically as possible, without, stepping on some
I can understand that.
guideline in the SEC, sort of explain, sort of the spectrum
Yes.
going from private to public, and in response to your question.
Yeah, we'll be watching Addimmune in the channel. I mean, that's how I got into watching you, Jeff, and with AGT, because I was looking at the disease vertical, upcoming companies that would go public, which we can catch early so that we can ride the profitability curve. So that's how I found American Gene Technologies. I got to talk to you. That thought is becoming much more stronger as you make more progress towards phase 2. So I think all our viewers who are investors, there's an investor side of our viewers, they are very keen to get shares of Addimmune once it comes into the market. And we hope for the best out there. The next question, Jeff, is that if I recollect properly, you were authorized to perform analytical treatment interruption along with phase 1, which is usually for safety studies. So I think you have published an article in bioRxiv about those results. Can you please share some information and data at a high level with our viewers?
Sure. So we did get some efficacy markers in the phase 1, but you're right. We added an analytic treatment interruption, so antiretroviral withdrawal after the phase 1. And one thing to keep in mind is that the phase 1 lasted, for each patient between 6 months and 1.5 years. So during that time, while they were still on antiretrovirals, before we withdrew their antiretrovirals, those cells were in their body unstimulated, and it is normal for the body to reduce the oversupply of those cells when they're not in use. It's actually called normalization in the immune system. So we were testing, the efficacy of those cells at much lower quantities than the initial infusion. And we think that that's sort of a key to the next study, is we won't wait, 6 months to 1.5 years to take people off of antiretrovirals. What we'll do is we'll infuse them with these cells that are designed to repel and control an HIV virus, right? And we'll take them off their antiretrovirals shortly after that infusion. And what that means is that there'll be a lot more cells that are working on the immune response than what we were able to utilize in this ATI. Okay, so that wasn't really your question, but I wanted to frame that because, when I tell you about the data, I think what makes it so remarkable in my mind is the understanding that this was not optimum conditions for the withdrawal study, right? You really don't want the body to eliminate, 90% of the cells before you go ahead and show them the virus, right? And see what the effect will be. So I think that the results that I'm going to tell you actually kind of understate my excitement over this. So what did we see? So when we took people off of antiretrovirals, what you would expect to see, like if you take anybody that's normally taking antiretrovirals every day and they're well controlled, so they have, sort of what's called undetectable viremia, that usually means it's below 20 particles per ml. It's undetectable in a standard HIV test. You take them off, what will happen is the HIV virus comes back out of the viral reservoir. So there's integrated copies. We don't even know where they all exist, but they're all over the body. They start producing virons that get into the bloodstream. And then, of course, in the bloodstream, they start doing what? Attacking CD4 cells. So you see CD4 cells decline. Right? That would make sense. Now, what doesn't happen when you normally take people off of their antiretrovirals, if they don't have some protection like what we put in other words, is that you won't get a normal immune response. A normal immune response would be that the CD4s would identify the pathogen. They would trigger a CD8 response. Okay, so you'd see CD8s go up. Right? This is what you see when you get the flu, right? You see CD8s go through the roof, right? That's why you swell up, actually, right? So, normal withdrawal, you'd see no response in the CD8s and you'd see a decline in CD4s.
Right.
6 out of 6 patients that we took off antiretrovirals did the opposite. The CD4s remained relatively stable,
Steady.
and CD8s went up.
That's
So that's
amazing.
really encouraging. Okay.
Yeah.
Now, what I would say is, especially technical people out there, download the article. Okay. The preprint is in bioRxiv, so you can see it right now.
Right.
So this is pre-publish, but it will, be peer reviewed and republished again. So the final article is coming out, but you can get the data. That I read the article. I think it presents it really nicely. So that's just step one.
Yes.
So we weren't really satisfied with the level of viral suppression, right? We saw a really nice immune response, which is, theoretically what we wanted to see. So that was a confidence building about sort of the whole theory.
Right.
But the question was, can we get a better effect of viral suppression? Because most of these folks rebounded up to 100,000 particles per ml over a relatively short period of time, like a month or two, right? And 100,000 particles per ml is too high.
Right.
Okay, that's not controlled. Now, we couldn't see what happens afterwards because, the immune system always starts off behind the virus.
Right.
When you get the flu, you have 50 million particles per ml before your immune system gets on top of it.
Oh.
Okay, obviously, if HIV got to that level, you'd be wiped out. So, and people consider it dangerous, really, to be above, well, certainly at 100,000.
So they had to go back on ART immediately.
So they go back on ART. We thought, hey, these cells now have seen the virus. It's sort of like a vaccine, right? So the first exposure to the virus should activate these cells. It should cause the CD4 cells to proliferate.
Yeah.
And they should be ready and in effector state for the next time they're exposed to the virus.
Right.
So we put them back on ART. We get them well controlled. And then we asked them, would you be willing to take your, stop taking antiretrovirals again?
Yeah.
4 of them agreed to stop. Out of them, all 4 got multi-log reduction in viremia from their first peak.
Wow.
So we were able to look at in the first ATI what their peak was, and the second ATI, and there was a huge difference between them.
Right. So your CD8 are all primed up and they were ready. As soon as ART was removed and new virions came in, they were attacking them, producing huge quantities of CD8s and keeping control.
Yeah. Now, control, in that it brought it down quite a bit.
Yes.
Still not to functional cure levels. The goal for functional cure has got to be less than 200 particles per ml. Maybe even, we'd hope to get it under 50 particles per ml, because that would be highly likely, or let's say, I think we could reach some consensus in the scientific and medical community about what level it's not contagious.
Right.
That U equals U, right?
Right.
That people don't have to worry about infecting anybody else. So that's got to be the goal. So what were we seeing? We were seeing one patient was hovering around 5,000 particles per ml. Okay, now that's really significant because 5,000 particles per ml is called a long-term non-progressor. So if that was durable, that response, they no longer need antiretrovirals to avoid AIDS.
Wow.
Yeah. That's a a milestone level. That's like sort of an important target number. It's not what we want to do, but it's a significant suppression, and we still have to do tests to see, well, how long does that last? Okay, we didn't see anything that said it wouldn't be durable, but we didn't. Some of these patients had been in the study for over 3 years at that point. We had to let them go back on antiretrovirals so that they could go back to their normal lives and stop coming down to the doctor to get a blood test every single week too.
Right.
So that's why we don't have durability information yet, but we're going to get this in the next study. We had a second patient that was almost at that level.
Right.
It was hovering around 10,000 particles per ml. That's still within the range that is considered by many to be a long-term non-progressor. So that's exciting. 2 out of 4 were at that level. The other 2 were within a half a log of that. Now, if you got a 2 log reduction from your peak, and remember, this was not the most optimum conditions. It would be better if you had more of those CD4 cells in your body. When we did this little vaccine step, right, where we expose them to the virus once, put them back on antiretrovirals, and then take them off again, right? So, we didn't expect much, but I think what we got was very exciting. So read the article. That's very exciting.
Absolutely.
And it informs us for the next study. What we're doing is we're figuring out what are all the changes we can make in the protocol. Doesn't change the drug at all. It's still the same drug. But could we drive this to a better outcome? Maybe we could get, a statistically significant number of patients below 5,000 particles per ml. That itself would have a tremendous amount of meaning. Why?
Yes.
Because if they're down at 5,000 particles per ml, guess what? They don't need as much antiretrovirals to control it the rest of the way.
Yeah.
As a matter of fact, there are other drugs out there that look like they could become like once every 6 month pills, right? Now, that would be a big improvement in HIV treatment. This would improve the lives of people that are living with HIV, because reduced antiretrovirals is likely to mean reduced side effects.
Right.
Reduced side effects means better, quality of life. But over the long term, it can be a substantial reduction in the cost, because long-term exposure to these chemotherapeutic agents are things like liver, kidney, heart disease, and cancer, right? Okay, so that would be amazing. Now, my hope is, again, remember, nobody has higher aspirations for this than me. My hope is that we will see some people that are controlled at levels where not only don't they need antiretrovirals, but they're just non-infectious, right? Non-infectious, not needing antiretrovirals gives you all the benefits of functional cure. Even if we demonstrate that in the next study, then we still have to show that it's durable. And then we also have to go back to the FDA and say, look what we just did, right? And now we could go back to them with 2 drugs. Right? We can go, for everybody, it reduces it to 5,000. Right?
Yeah.
And for some people, you get durable remission completely. And this is beneficial to the entire HIV population. Right? And that could be something that would be attractive to the FDA, because they could see the benefit. These populations, even folks that are in some of those rare subgroups of people living with HIV who have a lot of difficulty on ART. Right? That may be the thing that moves it across the line where they have a good experience with ART. Right? It's 4% of the population in the United States, roughly 3.8% of the population in the United States. ART is not working.
Multiple drug-resistant MDRs.
That's right. They're in a very difficult situation.
This could help them as the first point, like conditional licensing.
Look, it's a very fluid situation, right? It's a lot of collaborators, and we look at the FDA as collaborators, right? With absolute responsibility for safety, right? So, they're very valuable to us as a outside set of eyes to make sure we're doing what we want to do, which is to bring out something safely.
Absolutely.
So, so it's a long process. We need to show data. We need to, figure out what the next study is, show data again. And one day, hopefully, we'll be sitting down there with the FDA and we'll be defining endpoints for a BLA. And I'm optimistic about that. But, I think even more important to the people that are listening to this is I'm committed. I'm going to be doing this until either we prove we can cure HIV or we prove that we can't. Okay, I'm not taking we don't know for an answer. All right. Yeah. So we're in this for the long term, and I think that so far things look really, really good. This data was really supportive of my optimism, and I hope as people read the article, they'll feel this the same way.
I was thinking why there is so much of delay between phase 1 and phase 2, but now that I hear you describe the nature of the data that you got, I have a much better understanding. And I think that you're trying to be careful that you come up with a proper protocol. Maybe in the second phase, some plan for dose escalation or whatever needs to be done so that you can have a better outcome. And you don't want to lose the opportunity, because time is important, resources are important, and you already have tasted potential success with the ATIs in phase 1. So I can understand the entire team must be putting their heads together and consulting with the FDA and others to make sure that you have a really, really good plan for phase 2 before you actually get into it. But that said, Can you give us a sense of when the phase 2 might start, and also the possibility that you might look for a fast track designation or something from FDA? So
yeah, so first of all, let's be cautious about what we call this next clinical study, because we may not call it a phase 2. It's going to be a larger study with a modified protocol in order to gather statistical data to pursue a pivotal study. Okay, so it's an additional efficacy study. I don't know whether the FDA will call it a phase 2 or a 1B. It really doesn't matter, because the key is safety and efficacy, right?
Yeah.
So, and I think that what's interesting about a phase 1 in gene and cell therapy is that you can get, and I think we did get, efficacy data that is quite similar to a phase 2A efficacy readout.
Right.
Now, but the problem with the data that we got is it's not statistically powerful, right? You can be encouraged by it, but you can't draw statistical conclusions.
Right.
This is what the next study is for.
Okay.
We've got to repeat it enough that it's undeniable what this drug does, not just a pattern within a small number. Once you run the numbers, you can calculate the p-values and things like that, and you can say, okay, we have proven that what you see from here to here is due to the drug, at least proven, within reasonable statistical, conclusions, right? Okay, so that's the next study.
Right.
So now, I don't know when things like fast track cut in. We're open to anything. We haven't applied for anything specific yet, but we're, still searching around to figure out what programs we would qualify for.
Right.
To tell you the truth, I think the FDA is turning things pretty quickly for us.
Right.
Okay, they must, on their side, it doesn't seem like they're dragging their feet, right? They're waiting for us to give them what they need, and what they're asking for is reasonable stuff. And we're in conversations with them already, and they're productive conversations.
Yeah.
So, hopefully at some point something comes up where they go, hey, you qualify for this program or that program, we can put more resources into you. That would be wonderful. But in the meantime, we're going to find the resources somewhere, and we're going to keep pedal to metal on this program. Right. As quickly as possible.
So this all sounds encouraging, Jeff. I really appreciate you taking the time. Is there anything else you would like to tell our viewers, something that I might not have asked you, maybe you wanted to communicate, or we have covered it all?
No, I think, I'm always interested in, getting together with you, and I'm glad that you had some questions that you were getting from your viewers. And if you end up accruing additional questions, or you just want to do a check-in on progress, let's get together again.
Thanks a lot, Jeff. And I really think that we had a substantial discussion, and it's kind of giving more understanding of where you come from. And this has been a wonderful interview, Jeff. And I'll be really I'm thanking you on behalf of all my viewers. This is one of the best interviews we have had in a long, long time. And thank you so much for it, Jeff.
Oh, absolutely my pleasure. It's great to see you again, Raj, and let's keep in touch.
Yeah, and all the very best to Addimmune and the subsequent phases of testing.
Thank you. We'll hang in there, and we'll keep doing our best, and hopefully we'll have some more updates for you soon.
Thanks a lot. Take care, Jeff.
Thank you. Take care.
Yes.
Bye.